All right, why don't we begin the public comment session. At the onset, I'd like to welcome and thank the public comment speakers. Your comments are very important to us here on the voting committee, and we appreciate you taking the time to do so. All speakers today have submitted a request in advance of the meeting, and the final list of commenters was determined by a lottery. I want to say for the speakers, we have a limited amount of time for the public speaking portion of our meeting. So I'm going to ask you to please adhere to the 3-minute mark for your period of comments. It's extremely important that you stick with this so that we can get through everybody's comments. On your screens will be a circle that will cycle through 3 colors, and then at the very end, it will indicate that your time is up. At the completion of your time, I will say thank you for your comment. Your time has expired. If you exceed by 15 seconds, I will state, as a courtesy to other speakers, we ask that you conclude your comment. And then if you continue for 30 seconds after your time allotment, I will state your comment time has ended. Thank you, and your microphone will be cut. Again, I want to thank you all for doing this, and we'll proceed with our first speaker. So will Mr. Joshua Manson please come forward, and for all speakers, state your affiliation and your name as you come to the microphone. Thank you.
Thank you very much for this opportunity to speak at this important meeting. My name is Joshua Manson, and I'm a researcher at the UCLA Law COVID-19 Behind Bars Data Project. Dear members of the CDC's Advisory Committee on Immunization Practices, since the start of the pandemic, our team of data scientists and researchers has been collecting COVID-19 infection and death data in prisons, jails, immigration detention centers, and youth facilities directly from their respective agencies. This week, we convened around 400 experts in bioethics, the treatment of infectious diseases, public health, epidemiology, and criminology to urge this committee to prioritize incarcerated populations, including those in immigration detention, and correctional staff, including on-site healthcare providers, for receipt of a COVID-19 vaccine. The signatories to this letter are concerned that nearly half of state plans do not mention incarcerated people as a high priority group. We firmly believe that incarcerated people and staff in carceral facilities must receive equal treatment to each other and to other populations living and working in congregate settings. During today's session, I'd like to briefly highlight 4 points. First, this pandemic has wrought devastating consequences on the more than 2 million incarcerated individuals in this country and the many employees who work every day in jails, prisons, and other detention facilities. Roughly 250,000 incarcerated people have been infected by COVID-19, and close to 1,600 have died. More than 53,000 correctional staff have been infected, and over 90 have died. Incarcerated people are 5 times more likely to become infected with COVID-19 and 3 times more likely to die from it, as compared to their non-incarcerated same-age peers. This week, the Marshall Project reported that 1 in 5 people incarcerated in state and federal prisons in this country has tested positive for COVID-19, a rate more than quadruple that of the nation as a whole. Because social distancing is often impossible in overcrowded facilities, when the virus enters an institution, it spreads rapidly. For example, last month, the state prison in Lee County, Kentucky, where about 753 people are incarcerated, saw a dramatic spike from 0 cases to over 600 in a 2-week period, an infection rate of 86%. Second, carceral facilities are critical vectors of COVID-19 transmission to surrounding communities. This places a particularly devastating strain on rural health systems. For example, in the county where the Kentucky prison I just mentioned is located, there are no major hospitals. The nearest one has only 25 critical care beds. Third, incarcerated people and staff should be similarly prioritized for receipt of the vaccine, contrary to the preliminary plans of some states and the Federal Bureau of Prisons, which prioritize staff. Both populations are highly vulnerable to contracting the virus, and both will continue to transmit it as long as they live and work in congregate settings. Over 12 million people enter or are released from a prison or jail every year, and each day employees return home to neighboring communities. Because of this constant churn, both incarcerated people and staff will continue to spread the virus into the broader community until they are vaccinated. In light of the historical legacy of medical experimentation, the reality of coercive control in carceral environments, and the deep distrust many incarcerated people and their families feel toward correctional authorities, careful steps must be taken to respect the autonomy of
Thank you for your comment. Your time has expired.
Thank you.
Thank you. Our next speaker is Dr. Charles Lee. Dr. Lee.
Good morning and good afternoon. Thank you very much. I am Charles Lee, the President-elect of the American College of Correctional Physicians, and I would like to speak on behalf of the inmates and workers in correctional facilities. I have no conflicts. I would like to start by echoing many of the exact points that the previous speaker just met, and they all bear repeating. As we know from the daily news outlets and newspapers that coronavirus is significantly increasing throughout the United States, especially in correctional facilities. And we know why this is happening. Where else other than in a correctional facility do you see congregate living? Perhaps in homeless shelters. However, those in homeless shelters can go outside if they choose. There is a significant increased minorities in correctional facilities at a rate of 3 times that of the general population. Many of the inmates are older and elderly with many comorbidities. This has been significant because they have previously not had medical care and are undiagnosed and untreated. They are unable to abide by the CDC regulations. They cannot socially distance. They may not get masks. They may not get hand sanitizers. A correctional facility is an extremely difficult place to work. Many of the correctional officers, by necessity as a result of their job, must have physical contact and interactions with inmates. As was previously mentioned, this affects more than just the correctional facilities. It affects our community. It affects our community healthcare facilities. There are limitations of what treatments patients can receive in a correctional facility. They must be referred out to clinics, emergency rooms, hospitals, and ICUs, thereby placing an increased burden on those facilities, sometimes at the expense of community people. There's increased costs of this to the city, the states, and the federal government, all borne by taxes. We commend the ACIP for looking at this, and we hope that they approve the Moderna vaccine. It is needed. There's inadequate supply presently. We need more. We also hope that during tomorrow's discussion, that the ACIP consider inmate workers, inmates, and elevate them to phase 1B and 1C as the committee deems appropriate. Again, we thank you for this opportunity to express ourselves on behalf of the inmates, correctional workers, and the physicians and medical providers that care for them. Thank you very much.
Thank you for those comments. Our next speaker will be Ms. Susie Olson Corrigan, please.
Could I be pushed down further in the list? My computer just crashed.
I believe that's possible. Let me call the next speaker.
Thank you.
Welcome. Ms. Meredith Whitmire, please.
Hi, I'm Meredith Whitmire, Policy and Advocacy Director for the National Association of Nutrition and Aging Services Programs. Thank you for the opportunity to speak. On behalf of our organization and the 4 million older adults our members serve every day, we commend you for your excellent COVID-19 work and decisions made to date. I am commenting today to make several requests of this panel. My first request is also reflected in a comment submitted yesterday by my organization and Meals on Wheels America. In short, we are urging you to develop policy guidance to ensure that senior nutrition providers, staff, and frontline workers are clearly and consistently considered essential workers and given priority as such for COVID-19 vaccinations. As you all know, the pandemic has disproportionately impacted older adults who remain at increased risk of COVID-19 and face unique barriers to accessing adequate nutrition and socialization. There are few services more essential than providing meals to the millions of seniors who currently rely on them to prevent malnutrition and other serious health risks. Additionally, the senior population is increasingly at risk of the harmful effects of social isolation as a result of the pandemic. Enabling senior nutrition providers to obtain the vaccine quickly will enable them to interact more directly and in person with older adults in desperate need of human contact. In short, a clear and consistent directive from this federal panel designating senior nutrition providers, staff, and frontline volunteers as a priority population for the vaccination is urgently needed. My second request, which my organization has made before, is to suspend until the end of the pandemic your recommendation for shared clinical decision-making between patient and provider in deciding whether a patient should get the PCV13 pneumococcal vaccine. I make this recommendation for several reasons. The first is the new reality created by the pandemic with fewer older adults visiting any healthcare provider where this decision-making discussion would take place. The second real concern and consequence is that fewer older adults will be vaccinated against pneumonia at a time when we should be striving for greater vaccination rates, particularly as we enter flu season. Even prior to the pandemic, for African American and Hispanic older adults, the rate of PCV vaccinations is a full 10% and 15% lower than for white older adults, respectively. This pandemic has exposed the degree to which health disparities have contributed to the disproportionate rate that older minority adults have contracted COVID-19. We cannot maintain policies that, by their nature, exacerbate disparities. Finally, I also repeat our support for ACIP adding at least one member with expertise in geriatrics to better inform the work of the committee on issues of special significance to older adults. That expertise is even more important today during this pandemic. Thank you for your time.
Thank you for your comments. Ms. Olson-Corrigan, are you ready?
No, I'm not. I'm not sure if my computer's going to come back up. Is it possible to skip one more person to me again? Come back to me again?
If you don't mind, I'll move you to the very end of the queue and then come back to you then.
Thank you so much.
Thank you. Benjamin Newton, please. Benjamin Newton.
Thanks so much. Can you hear me?
Yes, we can, please.
Fantastic. Today, there's enough Moderna vaccine already produced to protect several billion people. How is this possible? A few facts plus some simple calculations support this conclusion. First, the data indicate that 92% efficacy is reached 14 days after a single 100 microgram dose. Second, 2 100 microgram doses induce an immune response 9 times as great as a single 100 microgram dose. Third, protection is immune response dependent. Finally, the immune response decrease is only 70% for each 90% decrease in dose. Using these few items, we quickly see that 2 10 microgram doses would result in 2 times the immune response as 1 100 microgram dose, while 2 1 microgram doses would evoke 86% of the immune response produced by a single 100 microgram dose. That is, we can achieve 86% of the immune response known to provide greater than 90% protection and vaccinate 100 times the number of people. On December 2nd, Moderna's CEO, Stefan Bancel, was asked about this ability to synthetically increase capacity through changes in dosing regimen. He indicated without confirming dose or regimen that Moderna is, and I quote, not naive to the fact that there could be ways to increase the output using different regime and or dosing. Moderna's manufacturing capacity is currently 2 kilograms per month, leading to a monthly capacity to vaccinate 20 million people at 100 micrograms per dose, 200 million people at 10 micrograms per dose, and 2 billion people at 1 microgram per dose. Practically, the end of the pandemic is limited only by the availability of syringes and our willingness to draw conclusions from the available data. If you don't want to use my calculations, Moderna has developed an amazing ability to predict human response based upon preclinical data and can certainly provide more accurate estimates than what I can provide using publicly available data. I expect that there will be understandable hesitancy to vaccinate people at a dose level lower than what was used in phase 3 trials. As As far as safety is concerned, lower doses were associated with fewer adverse events, but what about efficacy? Can we really risk vaccinating people with a dose that might be less effective? Regarding this concern, a compromise might be reached that allows 90% of the available vaccine to be administered in 100 microgram doses, the remaining 10% to be administered in 1 microgram dose. That would mean instead of vaccinating 20 million people next month, we could vaccinate 18 million people at 100 micrograms, an additional 200 million people at 1 microgram. Those who receive a lower dose could even still be eligible for a third dose later in 2021 when vaccine supplies increase. Given that 6 people have died from COVID during the time that I've been speaking, waiting until a lower dose has been formally studied in a months-long clinical trial feels irresponsible at best. Note that while these calculations were done on mRNA 1273, these ideas all apply to Pfizer-BioNTech's vaccine, which means there's more than enough vaccine to end the scourge of COVID today. We must all remember that 90% efficacy for 100% of the population is better than 94% efficacy for 10% of the population. It's only a matter of time until doctors, governors, and foreign regulators optimize vaccine supplies. It is better for the CDC and the FDA to lead those decisions today. Thank you very much for your time.
Thank you very much. Our next speaker is Lori Simonelli. Ms. Simonelli. Next speaker is Lori Simonelli. All right, let me jump. Are you ready, Ms. Simonelli?
Dr.
Let me move on to the next speaker after that, which is Mr. Bob Carey, and then I'll come back. Mr. Carey?
Thank you very much, Chairman Romero and members of the Advisory Committee. My name is Bob Carey. I'm the Executive Vice President for Advocacy and Planning at the Independence Fund, a veteran-serving organization. We will be sending over a letter here before the deadline from ourselves and at least 12 other veteran organizations regarding the applicability of the guidelines with the disabled veteran population. We agree with the ACIP's interim guidance and assessment that healthcare personnel and residents of long-term care facilities receive the vaccine in its initial phase, and we agree with the Department of Veterans Affairs plan to follow that guidance for healthcare workers within the Veterans Health Administration and residents of VA aggregate living facilities. We are especially interested in the apparent discussion by your committee at its 23 November 2020 meeting where the relative efficacy of prioritizing next after the healthcare workers, either essential workers or adults 65 and older, along with adults with high-risk medical conditions. While the discussion slides still prioritizing high-risk adults and essential workers averted more infections, it also showed prioritizing 65-plus adults and high-risk adults averted more deaths. For disabled veterans, this is especially relevant because many have compromised immune and pulmonary systems, driving them to forego their VA-provided home health care for fear of infection. And the ailments and disabilities which place these disabled veterans at higher risk may not be clearly and easily classified or are caused by toxic exposures for which there are not clearly defined diagnoses. Given that, we respectfully request ACIP consider the unique ailments and situations of disabled veterans in the prioritization of high-risk adults. Specifically, we believe high-risk disabled veterans should be considered for inclusion in Phase 1B. Further, we respectfully request ACIP consider some process by which Veterans Health Administration providers can classify disabled veterans as high risk, even if they do not fit into one of the high-risk conditions identified by ACIP. Finally, we respectfully request ACIP consider adding the caregivers who are so designated within the VA's PCAFC caregiver program to the appropriate phase for which the disabled veteran they support would be eligible, and to support their receiving a vaccine with their disabled veteran, preferably from the VA. And one of the problems the VA has in doing that is that they do not have current authority to provide medical care directly to caregivers, and so this would have to be part of their fourth mission, which would be federal support to state and local officials through the normal FEMA and HHS request process. So a recommendation from ACIP for VA to be able to do that under their fourth mission and their support to civilian authorities would be helpful. Thank you very much. Again, my name is Bob Carey with the Independence Fund, speaking on behalf of myself and 12 other veteran-serving organizations.
Thank you very much for those comments. let me go back now and see if Ms. Olson Corrigan is able to solve a computer problem. Will you be able to speak?
Yes, I'm here. Thank you so much.
Thank you very much. Go for it.
Okay, my name is Susie Olson Corrigan. Thank you so much for the opportunity to speak today, and I do apologize for the technical difficulties and delay there. I'll move quickly through my talking points. I've been attending all these ACIP meetings as well as the FDA VRBAC meetings to better understand the various vaccine candidates and their benefits and limitations. One thing that I've been really concerned about is the fact that the studies were not designed to show that these COVID-19 vaccines will stop transmission of SARS-CoV-2. However, we did see that the vaccination could lessen symptoms or even allow for asymptomatic carriers. Since the beginning of this pandemic, we've been inundated with the fear that silent spreaders, asymptomatic carriers, and pre-symptomatic individuals were a large component of increasing this pandemic. So I'm curious as to why that component of stopping the transmission of the virus was not included in these safety studies. There's also no guaranteed immunity from these vaccines. There's no long-term safety data, and now they are unblinding and vaccinating the placebo groups. These placebo groups provide a critical point of comparison in gold standard clinical trials, allowing researchers to study long-term side effects over time. By unblinding and vaccinating the placebo arm of these studies, we lose this valuable data. So how do you plan to track those long-term effects? There's also no manufacturer liability. Under the PrEP Act, the manufacturers hold no liability. The FDA holds no liability. Your employer, even if they mandate this vaccine or coerce you in some other way to receive the vaccine, they also hold no liability. So if you experience an adverse reaction, as thousands of people are, you are the only one that's responsible. You're responsible for that time off work. You're responsible to deal with any medical consequences that come. You are 100% responsible for what happens to you. So you are coerced into receiving a liability-free pharmaceutical product, and then you are the only one there left to pick up those pieces. I've experienced this in my personal life, and I can tell you it is a terrible experience. By getting this vaccine, you're still going to have to wear a mask. There's still going to be restrictions in place. You're still going to have to socially distance. So I'm just wondering what is the point of these vaccines? The FDA approved this, but they approved it under EUA, Emergency Use Authorization. I don't think that the general population understand the difference between FDA approval and EUA. I've spoken to several people that say, oh, it's FDA approved, but it's not. This is emergency use. They need to understand that that is not the same safety standard. The last thing I'll say is, antibiotics didn't need a big marketing campaign like these vaccines do because they worked. They're safe and effective, and they've been proven to work. If these vaccines are so safe and effective, we shouldn't need constant inundation in the news, in the media, with everyone getting this vaccine safe and effective, safe and effective, safe and effective. I'd really urge you guys to consider some of these points today. Thank you.
Thank you for your comment. It's been greatly appreciated. Ms. Simonelli, I'm told that you're
yes,
maybe...
Can you hear me?
Thank you. Yes, thank you. Go forward.
Okay, yes, I'm sorry. I didn't understand how to use a Zoom call, so that's what I didn't have So can I begin now? Good afternoon.
Yes, please go forward.
Okay, good afternoon. I find it astounding that an investigative experimental fast-track vaccine with zero liability is pushed to be delivered worldwide. Your own data claims a 99% recovery rate from COVID under the age of 74 without comorbidities. Above the age of 74, it's a 94% recovery rate. Yet a concoction from chemists paid millions of dollars have created a politicized potion to stamp out the virus. 70% vaccination is required to achieve herd immunity, says Dr. Fauci and the likes of your agencies. So still live with mass social distancing, bankrupt economies, and isolation. Experts, including your own agency, comment that natural acquired COVID may only provide 3 to 4 months immunity. This is more magic. No one has the confirmed data. This vaccine is experimental and liability free. You have claimed humanity as your test subjects. It is so wrong. The fastest vaccine previously created was the mumps vaccine in 4 years. And we have watched that fail over and over with 100% compliance. You want to go first into the elderly and long-term care facilities, alleging it's for their greater good. So without zero voice in the decision, your agency recommends, and other agencies like you, to keep them locked in with staff and isolated. So how did that work? Failure to thrive, cognitive decline, isolation, broken hearts. Yet in the greater good, this must happen. Well, it's been 9 months. Surges are still occurring in long-term care facilities. My mother's facility, November 7th, acquired 1 case. By December 4th, it ballooned to 103 cases. All facility residents were involved, 50 staff. Your recommendation is to keep family out. I wonder psychologically if they wouldn't have had a better opportunity to recover if we weren't allowed in. Wearing a PPE doesn't take a rocket scientist. I'm very disturbed with the elderly population not having a voice, and your determination of a panel of doctors making a recommendation that go give them all the vaccine. And how long do they plan to be incarcerated? How long? Not human contact, not love. It is proven medically that people recover better when they are in a better state of mind. Now you've determined you will vaccinate all of them, but the data is not there.
Thank you for your comments. Your time has expired.
Thank you.
Thank you. I wish to thank all the public speakers for taking the time to address the ACIP. And so, Dr. Cohn, do you want to move forward with further discussion on our last topic, or can we give the group a 5-minute break?
We can give the group a 5-minute break, and then we can come back and continue to discuss the prior presentation. I see everyone put their hands down, but you're welcome to put your hand back up if you had a question from previously. And then we'll come back at 3:07, and then we will vote on the motion on the table after discussion on the clinical considerations is complete.
Thank you.
So can we return at 3:07?
So we will return at 3:07. Thank you.